Thank you. Hugo, any comments?
Well, to me, when this happens, what I try to do is, since you have or induce a tear with the suture, what I try to do is to put another suture posteriorly as to be covered with a band. And I think this subretinal hemorrhages depends on how close are to the macula first, how old is the patient. If you have a young patient and the subretinal blood is not too thick, I think in a healthy RPE, this blood may reabsorb without the need to take it out. So all depends how thick it is and how close to the macula is. Obviously, you did a great job, so it was a very nice maneuver, and you are demonstrating that you can do that, but what we should learn is that not always it could happen.
And Andrea, you also presented the case earlier where you had an incarceration during scroll buckling, and that was during the drainage that you have. Do you want to comment on that and how to prevent that from happening?
Yes, every time we do a scleral buckling, something happens like this, or in retinal incarceration, we think about not stop doing scleral buckling. And it's hard to teach, it's hard to do. Vitrectomy is much easier, but I still do it. I think for certain cases, specifically younger patients with inferior retinal detachment, that's what I do. So to reduce the risk of having that, I think you have to be very, very careful in those cases. To reduce the risk of retinal incarceration, you have to reduce the velocity of drainage. So you cannot do it very fast. Do it slowly to avoid this complication.
Do the panel do anything special on, now many of our patients are currently on anticoagulation, especially the older patients. Do they do anything special in that regard if you're doing a scroll buckling? Any comments?
Don't do too much backlings, actually.
Jeff, do you do anything special?
Well, if the INR is less than 3.0, I do proceed with the surgery.
3.0. My limit was 2.5, so it's good to know. And you know, so the comment is, if you get an incarceration or if you get a break, if you can move the scroll buckle, you want to have that buckle cover the break. In this case, generally, I think if it's a macula on retinal detachment, usually the macula is protected most of the time, so it's not a concern. This usually happens either during the drainage or during the passing of the suture. You may get some retinal hemorrhage that under the macula because the macula is off. If it's a clot as large as it was as yours, I think it ends up needing to be removed. But if it's a mild bleeding, usually you do fine. Now, sometimes you may get bleeding during the vitrectomy. You know, sometimes your retinal tear, retinotomy, you have bleeding. We put perfluorine in and that blood is peripherally. You do an air fluid exchange, and now suddenly all that blood ends up being posteriorly. And then the question becomes, should I drain this or leave it alone? When the blood is that mobile, as Hugo pointed out, many times you can just leave that. When you do air fluid exchange, when you put that gas bubble in, you have that patient positioned face down. That face down positioning will again remove the blood away from the posterior pole. So when you see that patient post-op day 1, usually you do not see blood posteriorly. And obviously, during the surgery, during the drainage, I think the key is to have that in a slow process. You do not want to do a fast drainage, large needles, or a blade, because that flow may lead to the incarceration of the retina and making it a bigger problem.